Welcome to Part 2 for Chapter 57, Nursing Outline. This chapter explains the following diseases: gastroenteritis, peptic ulcer disease, and gastric cancer. Here is the outline of this chapter.
Med-Surg chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I would like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. Welcome back. This is chapter 57, coordinating care for patients with stomach disorders. In our last video, we mastered the vocabulary of this chapter, the stomach disorders key term. Now that we are going to put them at work. In this video, we are going to define those diseases like gastritis, gastroenteritis, peptic ulcer disease, gastric cancer, and each of them they have if they have types of or epidemiology, pathophysiology, clinical manifestation, interprofessional management. Here we have any lab surgeries and any treatments, diagnostics, and nursing intervention and action that we have to do. So also we'll cover the medication that you need to know, like PPI and sucralfate. What you will learn from this chapter 57 to become easier to understand, like gastritis, why NSAIDs and H. pylori are the biggest enemies of the stomach lining and how to treat it. Gastroenteritis, why rehydration is the #1 key priority for the stomach flu. Peptic ulcer disease, the distinct differences between duodenal ulcer, pain relief by eating, and gastric ulcer, pain worsened by eating. Gastric cancer, risk factors like smoke food and identifying vague early symptoms. Pharmacology, mechanism of action for PPIs like omeprazole, the H2 blockers and mucosal barriers, which are the sucralfate. I like this image made by Gemini, and in chapter 57, here it's the little stomach faces. And these are the disorders: gastritis, gastroenteritis, peptic ulcer, gastric cancer, can affect digestion and nutrition. And this here little guy, the stomach, very happy face and food coming from esophagus, the reservoir of large meals. This is a really nice picture, and here are like more the lining of the stomach, the gastric mucosal lining. So the introduction, here it's I just said like a little bit of how the stomach's role in digestion, mixes crumbs of food and transports it to the duodenum here. The function acts as a reservoir, performs early stages of protein and carbohydrate digestion, absorbs water and alcohol. The gastric mucosa contains a deep glands with parietal cells, secrete hydrochloric acid and intrinsic factor, and the chief cells secrete pepsinogens. Mucous cells secrete mucus and bicarbonate to protect the stomach lining. Prostaglandins are key protective mediators, improving blood flow and increasing mucus and bicarbonate secretion. The mucosal layer has a high turnover rate, allowing rapid healing without scarring. So common disorders: gastritis, gastroenteritis, peptic ulcer disease, and gastric cancer. So we go one by one, and we'll see how each of them we can treat the patients when they have one of those following disorders. Gastritis, the inflammation, it is. First, think of this simply as inflammation of gastric mucosa, the stomach lining. Gastritis, the inflammation. So it's the inflammation of the gastric mucosa, stomach lining. And this is a nice pictures of how it looks, the gastritis, acute versus chronic. I use Gemini to give me this wonderful picture to make it easier to understand rather than just having the flashcard available. Here it's the little logo of Gemini. So the patho, it's normally your stomach has a protective mucosal barrier. Gastritis happens when that barrier is broken. The top two enemies of this barrier are NSAIDs like aspirin and ibuprofen, and the Helicobacter pylori. When that barrier breaks, acid touches the stomach wall, causing edema and bleeding. Acute versus chronic. Acute is sudden. Think of someone who drank too much alcohol or took too many NSAIDs. It hurts, but it heals quickly. Chronic is usually caused by H. pylori and lasts a long time. The danger here is that it can lead to pernicious anemia because the stomach loses the ability to absorb vitamin B12. Treatment: we treat it by removing the cause, stop the NSAIDs, and suppressing the acid with PPIs and H2 blockers to let the stomach heal. We mentioned before, so the gastritis, it's localized or patch inflammation of the gastric mucosa. The types: acute versus chronic. So the acute lasts a few hours to days, characterized by mucosal inflammation, hemorrhage, and in severe cases, slurring that can lead to GI bleeding. Here actually it's my notes. You can take a short screen and have it ready to study. I think having all in one page make it easier and it's all available in one glance. So we have the epidemiology and pathophysiology. So the causes, it's that on acute causes, indigestion of irritating foods, alcohol or medication, aspirin, NSAIDs, complications of acute illness, it's burns, infections, major surgery, infected bacteria like Staphylococcus, E. coli, radiation therapy, indigestion of poisons. Stress-induced gastritis, a severe form caused by inadequate mucosal blood flow during intense psychological stress, shock, trauma, major surgery. Chronic gastritis, the H. pylori, the most common cause, a spiral-shaped bacterium that colonize the stomach by producing urease to neutralize acidity. Alcohol, NSAIDs, Crohn's disease, tuberculosis, bile reflux, associated with antibodies to parental cells and intrinsic factor, which can lead to pernicious anemia due to B12 malabsorption. Clinical manifestation, we have the common symptoms: epigastric pain, sometimes exacerbated by spicy food, nausea and vomiting, weight loss, and decreased appetite, changes in stool color. Atrophic gastritis may have no symptoms, severe causes, dehydration or upper GI bleeding, which can lead to hypovolemic shock, like pallor, tachycardia, hypotension. We have intra-professional management. Diagnosis can be based on symptoms alone, upper GI, X-ray or endoscopy. With biopsy it's needed, fecal occult blood tests to check for hemorrhage, urea breath testing, serological testing, and fecal anti-aging testing to detect H. pylori infection. In the key terms, in the previous video of this chapter, the part 1, I actually have a picture about this urea breath testing. So the treatment, supportive care, relieving symptoms and removing the cause, GI rest and PO for nothing by mouth, and PO for 6 to 12 hours, followed by a gradual reintroduction of liquids and then solid foods. Avoid irritating foods, caffeine, spicy foods, and medication like aspirin and NSAIDs. Medication like proton pump inhibitors, PPIs, esomeprazole, lansoprazole to inhibit acid production. The H2 receptor antagonist to block gastric secretion, antacids like Malox, Mylanta to neutralize gastric acid, sucralfate, the caraphate to create a protective physical barrier, vitamin B12 supplementation for chronic gastritis associated with pernicious anemia. The H. pylori eradication. Combination therapies like PPI with 2 antibiotics for 7 to 14 days. Surgical management rarely needed, only for severe hemorrhagic gastritis when other measures fail. Surgical option, vagotomy, partial or total gastrectomy, or pyloroplasty. Pyloroplasty, I have a nice picture in the key terms exactly, and how it's this kind of made. The picture, I think it's very nice. Nursing management. So we assess the symptoms may include like dyspepsia, epigastric pain, nausea, vomiting, weight loss, and stool changes. So the nursing diagnostic is acute pain, anxiety, deficient, acknowledged risk for deficient fluid volume. Nursing intervention, we do the assessment first, like for everything, vital signs, then signs and symptoms, laboratory for H. pylori, serum, electrolytes, and intake output. The action is administered IV fluid per doctor's orders, H2 receptors, antagonists, antacids, and PPIs as were prescribed. Teach the patient to report for hematemesis immediately. Take medication as is prescribed by the physician. Avoid irritants, NSAIDs, alcohol, spicy foods, and follow dietary guidelines for reintroduction of food. For the evaluating outcome, patient will recovers in about 1 day due to gastric mucosa regenerative ability. Expected outcome, normal vital signs, decreased pain, reduced anxiety, and compliance with the therapeutic regimen. Next is gastroenteritis. Here, gastroenteritis. While gastritis is just the stomach, gastroenteritis involves the stomach and the small intestine. So the gastroenteritis is the stomach flu. Here it's another beautiful picture made by Gemini for gastroenteritis, the stomach flu. Here are the symptoms, and here it shows like how does either the viral or bacterium involves the stomach, and the causes, it's usually viral, like norovirus, it's the number one, but it can be bacterial like salmonella or E. coli. No washing hands or unwashed food, or food they are very old. Symptoms, it's the hallmark signs are watery, diarrhea, and vomiting. The big priority, you don't usually give antibiotic for this. The number one priority is rehydration. We are worried about hypovolemic shock from fluid loss, so focus on oral hydration solution or IV fluids, because when it's a lot of diarrhea or vomiting, it's a lot of liquids that body loses. here is my notes for this disease, the gastroenteritis, a self-lining illness characterized by inflammation of the stomach and small intestine. So we have here like the watering, diarrhea, abdominal pain, cramping, nausea, vomiting, and sometimes fever. Alternative names, they call it stomach flu, travel's diarrhea, or food poisoning. Causes, most cases are infection, virus, bacteria, or parasites, but it can also result from medication or chemical toxins. The epidemiology, virus related, leading the cause, the norovirus and rotavirus are most common, transmitted by fecal, oral, contaminated food or water, or airborne routes. Bacteria can be caused by Salmonella, Shigella, Botulium, E. coli, etc. So from Salmonella and Campylobacter, from raw, uncooked poultry, seafood, or unpasteurized milk. Shigella is from person to person via fecal oral route. Parasites is Giardia, and Giardia is more common in pediatric. And Cryptosporidium are common, often acquired via person-to-person contact in setting like daycare center or from contaminated water. Other causes, adverse effects from antibiotic, food allergens, enzyme deficiency, or toxins. The use of acid suppressing medication like proton pump inhibitors, the PPI, may increase the risk. Pathophysiology, the primary reaction is increased luminal fluid in the bowel that cannot be absorbed, leading to diarrhea, dehydration, and electrolytes loss. Viral wise, virus like rotavirus infect the enterocytes, causing maldigestion of carbohydrates and inhibiting water reabsorption. Bacterial, it's from stimulates the hypersecretion of fluid and electrolytes, causing watering, diarrhea. So for the exotoxin, causes rapid onset of nausea, vomiting, and diarrhea. Mucosal invasion, like Shigella, invades the mucosa, causing ulcerations, bleeding, and protein-rich fluid. The resulting diarrhea may contain the white blood cells and red blood cells. Parasitics like Giardia adhere to or invade the mucosa, causing diarrhea and potentially a chronic malabsorption syndrome. Clinical manifestations, signs and symptoms: diarrhea, nausea, vomiting, anorexia, abdominal distension, hyperactive bowel sounds, dry mucous membranes, and signs of dehydration, poor skin structure, decreased blood pressure. Nervous system affects some agents like the botulium, and certain chemical toxin can cause neurological symptoms such as headache, tingling, blurry vision, weakness, and paralysis. For interprofessional management, medical management, diagnostic, primarily through clinical evaluation of stool culture, PCR, and assays are also used. Stool testing is stratified based on the type of diarrhea, watery, inflammatory, or bloody. Treatment: supportive care, oral or IV rehydration. It's the main treatment. Medication: antidiarrheals like loperamide if fever and blood are absent and certain bacterial infection are not suspected. The bismuth subsalicate for cramping, antiemetics for vomiting. Antibiotics are prescribed only in select cases after stool culture results are known. Diet: start with clear liquids followed by a gradual reintroduction of bland, easy-to-digest foods. Avoid caffeine and milk products. Nursing management: the assessment is vital signs, including orthostatic measurements, abdominal distension, bowel sounds, and elimination patterns. Serum electrolytes, boom, and keratin to evaluate hydration. Intake and output: perineal skin status and signs of hydration, skin turgor, mucous membranes. Pain level, of course. The action: perform meticulous hand hygiene, administer high IV fluids and prescribe medication per physician, provide clear liquids or oral rehydration solution, provide uninterrupted rest periods, and apply the VTE prophylaxis, provide meticulous perineal and oral care. Teaching the patient: to educate the patient and family on dietary modification and preventive measures like proper food preparation and hand washing, especially when traveling. Inform them about the retrovirus vaccine for infants. Evaluating care outcome: the patient consumes the prescribed diet without diarrhea, nausea, or vomiting. Intake output are balanced and there are no further signs of fluid loss. Pain is managed and laboratory values and vital signs are stable. The patient can identify causative factor and demonstrate preventive behaviors. And that's it for gastroenteritis. Peptic ulcer. This is when the erosion goes deep through the mucosa and into the muscle layers. So this is a section 3 peptic ulcer disease, the erosions. In the key terms, I had this picture that showed the difference between the gastric ulcer and duodenal ulcer and how they are the opposite. So the gastric versus duodenal, this is the NCLEX favorite. You must note the difference in pain patterns. Duodenal ulcer pain is relieved by eating. Why? Because food buffers the acid. The pain comes back in 2-3 hours later when the stomach is empty. Gastric ulcer pain is worsened by eating. Acid secretion increases the digest the food, hitting the ulcer and causing pain immediately. Complication, hemorrhage, look for hematemesis, vomiting blood or melemma, black tardy stool, perforation. This is a medical emergency. The ulcer burns a hole through the stomach wall. The classic sign is a rigid, board-like abdomen and sudden severe pain. I hope you like this picture. So now we go into the notes of this disease. Here is my peptic ulcer disease, my notes. So it's a break in the mucosal lining of the GI tract that exceeds into the submucosa. Erosions are superficial breaks without measurable depth. Type duodenal ulcer, approximately 80% of the causes. Cases affecting the proximal small intestine, chronic with remissions and exacerbations. The gastric ulcer tend to occur in the laser curative of the stomach. The epidemiology and pathophysiology. It's common in the United States, affecting people age 25 to 64 years old. The risk factor is H. pylori infection and NSAIDs use. Other contributing factors is like familial tendencies linked to intrafamiliar H. pylori infection. Medication condition, medical condition like COPD, chronic renal failure, excessive cigarette smoking and alcohol ingestion. Rare cases, we have the Solingen-Lesion syndrome, where a tumor secretes gastrin, causing profound acid secretion. Pathophysiology. This disease can result from an imbalance between mucosal defense and the damaging effects of the gastric acid and pepsin. The H. pylori release a toxin that promote inflammation and ulceration. NSAIDs damage the mucosa by both topical irritation and systemic inhibition of protective prostaglandins. This increases gastric acid secretion and decreases mucosal blood flow and mucus production. Clinical manifestation, many patients, especially older adults, have a few to no symptoms. The duodenal ulcer pain, burning, epigastric pain that is aggravated by fasting and improved by food or antacids, may awaken the patient from sleep. Gastric ulcer pain is triggered or worsened by eating, leader to no relief from antacids. The pain characteristics located in the epigastrum may radiate to the back or shoulder. Often presents with periodicity, recurs at intervals of weeks or months. Sudden intense epigastric pain may indicate a complication like perforation. The medical management, the diagnostics, based on clinical presentation, but require differentiation from other conditions. Upper GI endoscopy is the preferred method for confirmation, allowing for biopsy to rule out H. pylori or cancer. Non-invasive tests for H. pylori include serum antibodies, urea breath, and stool antigen tests. Laboratory tests, CBC for anemia or inflammation, fecal occult blood, and liver pancreatic function test. Medication, the goal is for pain relief, ulcer healing, and prevention of reoccurrence. The PPI, omeprazole, and H2 receptor antagonist, ratididine, to suppress gastric acid. It's not more popular ratididine now. It's something else, but in this class, H2 receptor antagonist to suppress gastric acid. The sucralfate and misoprostol to enhance mucosal defense. The antibiotic to eradicate H. pylori infection. We have the diet, avoid dietary irritants like spices, alcohol, and caffeine. Encourage 6 small meals or small hourly meals. Discourage cigarette smoking as it impairs healing. Surgical management usually reserved for non-healing and bleeding ulcer or complication. Option over swelling, bleeding ulcer, patching perforated ulcer, distal gastrectomy, vagotomy, serves vagal nerve to reduce acid, or pyloroplasty enlarges the pylorus opening. Complication, we have the most common GI hemorrhage symptoms like hematemesis, vomiting blood, and melemma, black tardy stool. Treatment, fluid resuscitation, PPIs, and blood transfusions. Most common reason for emergency surgery is the perforation. Symptoms sudden, intense abdominal pain, rigid abdomen, abdominal guarding, can lead to peritonitis. Other complications, obstruction, peritonitis, and an increased risk of gastric adenocarcinoma in patients with H. pylori. Nursing management, we have the assessment vital signs including orthostatic measurements to detect fluid volume deficit, gastric pH, and occult blood in emesis feces, history of alcohol, tobacco, and NSAIDs use, serum electrolytes, and boom. Pain characteristics and the relationship to meals, diet, CPC, and weight. Clinical manifestation of complication like abscess formation. The action, maintain IV infusion and administer blood products and prescribe medications, PPIs, antacids per physician. Prepare for diagnostic procedure or surgery. Limit food intake before bed to reduce nighttime acid production. Teaching the patient is to emphasize taking medication as is prescribed per physician. Advise patients to avoid eating within 2 hours of bedtime and to avoid risk factors like NSAIDs and caffeine. Evaluating the outcome is decreased pain, uh, rating of 3 or lower on 0 to 10 scale. Consuming the prescribed diet without symptoms, no further signs of fluid loss. Here is a zoom out of gastric versus duodenal ulcer and how you can distinguish between. Here is the location, prevalence, and pain. Antacids, the acid risk, and gastric food makes stomach to work, leads to pain. Duodenal food coats intestine, which is give a relief. Here it's another little table: gastric ulcer, duodenal ulcer. Gastric cancer. Finally, we are in the last disease for this chapter. A cancer of a GI tract, most commonly an adenocarcinoma that infiltrates the mucus-producing cell of the stomach. It is one of the most common forms of cancer worldwide. The prognosis is the 5-year survival rate is approximately 23%, and the prognosis is dependent on the stage at diagnosis. Risk factor: H. pylori is a common cause, along with a diet high in smoke, pickled or salted foods, low fruits or veggies. The problem is usually asymptomatic until it's in late stage. Early symptoms like indigestion are often ignored. Surgery and dumping syndrome: if we remove part of the stomach, gastrectomy, we risk dumping syndrome. This is when food dumps into the small intestine too fast, causing dizziness, sweating, and diarrhea 15 to 30 minutes after eating. The management is to teach the patient to eat small, frequent meals, and this is the key. Do not drink fluids with meals. The pathophysiology and the epidemiology: the prevalence is the highest in Hispanic, African, and Asian population, and affects males twice as often as females. So affects males twice as often as females. So risk factor: the diet rich in smoked food, pickled vegetables, salted fish, meat, and nitrates. Low gastric acidity means acolorhydria, which allows bacteria to convert nitrates into carcinogens. The H. pylori infection, a significant risk factor, and its eradication is cornerstones of prevention. Chronic atrophic gastritis, chronic inflammation, high alcohol consumption, cigarette smoking, and the family history. The pathophysiology of gastric cancer is progression is a multi-step process from chronic gastritis to atrophy, intestinal metaplastia, and eventually adenocarcinoma. Most gastric cancers are adenocarcinoma. Those can be classified as the less aggressive intestinal type or the more aggressive diffuse type. Metastases occur early because of the stomach-rich blood and the lymphatic supplies. Early signs in clinical manifestation, often asymptomatic or has non-specific symptoms, making early detection difficult. Symptoms may include indigestion, anorexia, weight loss, vague epigastric pain, and a feeling of fullness. Pain is often ulcer-like and occurs after meals. In advanced stages, symptoms become more severe and do not respond to antacids or diet changes. May include palpable abdominal mass, nausea, vomiting, obstructive symptoms, iron deficiency, anemia, enlarged lymph nodes, weakness, fatigue, and weight loss. For medical management, diagnosis can be barium X-ray studies, chest X-ray for metastasis, esophagogastroduodenoscopy with biopsy. It's the preferred method of direct visualization and confirmation. CT scan and endoscopic ultrasonography are used for staging. The lab studies may show anemia, low in hematocrit, hemoglobin, elevated liver enzyme, and a positive stool guaic. For medication, is no specific medication for the cancer itself. Chemotherapy and radiation are primarily used for palliative care or to control metastatic spread. Antiemetics, opioid analgesics, and vitamin supplementation are used for symptoms management. Surgical management, surgical resection is the preferred treatment, particularly for early stages. Laparoscopic surgery and adjuvant chemotherapy, radiation may be curative options. More advanced cases may require partial or total gastrectomy. Palliative resection may be used to improve quality of life. Complication, dumping syndrome, the most common complication after a gastrectomy. Concentrate chyme enters the small bowel rapidly. Early symptoms is like 15 to 30 minutes after eating, causes dizziness, tachycardia, pallor, sweating. On the late symptoms, 1 to 3 hours after eating, hypoglycemia, weakness, sweating, dizziness. Other complication, wound infection, anastomotic leaks, strictures, and internal bleeding. Nursing management, the assessment is the physical examination for signs of metastasis, abdominal mass, ascites, and lymph nodes. Laboratory values like hematocrit, hemoglobin, electrolytes, and liver function tests, comprehensive pain assessment, early symptoms of dumping syndrome after surgery, the patient level of anxiety and need for end-of-life care. The actions encourage small, frequent, high-protein and high-calorie meals with dietary supplements as needed. Provide emotional support and counseling. Prepare the patient and family for surgery. Administer prescribed medication for pain and symptom management. Teaching the patient, provide information about the disease, diagnostic test, and treatment plan. Teach the patient and family about dietary modification, including signs of dumping syndrome and how to avoid it. Encourage relaxation techniques and coping stages to manage stress. Evaluating care outcome for gastric cancer is the patient demonstrate reduced anxiety, stable weight, and relief of pain. The patient consumes the prescribed diet without nausea or vomiting. Patient and family can verbalize an understanding of the diagnosis and management plan. Here I made for dumping syndrome, the nursing intervention and the dietary modification for management dumping syndrome. The diet plan for dumping syndrome, the primary goal is to slow gastric emptying, to slow down gastric emptying to prevent rapid movement of food into the small intestine. Meal frequency, I said eat small frequent meals rather than large ones to reduce the volume of food entering the intestine at once. Fluid intake, consume liquids and solids at separate times. Do not drink fluids with meal, as this helps facilitate adequate nutrient intake without accelerating emptying. Food to avoid, strictly avoid high sugar food like sweetened cereal, donuts, cakes, pastry, candies, cookies, soda, juice, or syrup. Sugar can cause the stomach to empty too fast, triggering symptoms. Nutritional focus meals should be planned to allow smaller bolus of undigested food to enter the intestine. Why this help? Because dumping syndrome occurs when concentrated, partially digested food, the chyme, enters the small bowel too rapidly, causing abdominal distension and rapid glucose absorption. This can lead to symptoms like dizziness, tachycardia, sweating, and hypoglycemia. Clinical manifestation for early and late stages of dumping syndrome. I said that the early, it occurs between 15 to 30 minutes after the meal, and then symptoms: dizzy, tachycardia, pallor, sweating, diarrhea, palpitation. The late dumping syndrome occurs 1 to 3 hours after the meal, and it caused by increased release of insulin following a rapid rise in blood glucose, leading to hypoglycemia, low blood sugar. Symptoms: weakness, sweating, dizziness. Because both stages can be serious, the text emphasizes managing this condition throughout the diet plan we discussed earlier. Small meals, separating liquids and solid. From this chapter, I made RN responsibilities for these 4 stomach diseases. The gastritis. The assessment monitored the viral signs, check for increased heart rate and decreased blood pressure, which may indicate fluid volume deficit from vomiting or blood loss. Reviewing history, assess for presenting signs like heartburn, indigestion, nausea, and precipitating factors such as NSAIDs or alcohol use. Monitor the labs, check for H. pylori, breath and stool test, and serum electrolytes like potassium may be low from vomiting. Track intake and output in and outs. Monitor for fluid imbalance caused by poor intake or vomiting. Action: administer fluids per physician. Give the IV fluids as prescribed if nausea and vomiting threaten fluid balance. Administer medication. Give prescribed by physician the H2 receptor antagonist, antacids to buffer the pH, and proton pump inhibitors like PPIs to suppress the acid. The teaching dietary management instructs the patient to follow the progression of NTO, nothing by mouth, 6 to 12 hours to clear liquids, then heavy liquids, and finally solid foods. Advise avoiding caffeine and spicy foods. Medication safety: teach the patient to avoid NSAIDs and to take prescribed medication until discontinue. The worrying signs is to instruct the patient to immediately report hematemesis, vomiting blood. For the gastroenteritis, the RN responsibility, the assessment monitor hydration status, check for orthostatic changes in viral signs, dry mucous membranes, poor skin turgor, and oliguria, low urine output. Abdominal assessment, check for distension and hyperactive bowel sounds. Skin integrity, assess perineal skin for breakdown due to diarrhea. The RN action: rehydration, administer IV fluids per physician. If the patient cannot tolerate oral liquids, provide oral hydration solution or clear liquids as tolerated. Infection control: perform meticulous hand hygiene with soap and water, especially for C. difficile, for C. diff, or norovirus. Conform measure provides its path for perineal irritation, frequent oral care, and allow for interrupted rest. Medication: give diarrheals like loperamide if prescribed and appropriate. Fever or blood absent. Then teaching prevention: educate on proper food preparation, hand hygiene, and precaution when traveling. Diet: teach to avoid caffeine and milk products initially and slowly reintroduce bland fluids. For peptic ulcer disease, RN responsibilities. The first is to do the assessment, the pain to monitor, assess pain characteristic, burning, epigastric pain, timing, relation to meals, and severity. Signs of bleeding: monitor for orthostatic hypotension, tachycardia, melena, which is black tardy stools, or hematemesis. Lab: monitor CBC for low hemoglobin, hematocrit, and check gastric pH, occult blood in emesis or stool. Risk factor assess for use of NSAIDs, aspirin, tobacco, or alcohol. Action, restore volume, maintain IV access and administer fluids or blood products as prescribed for GI bleeding. Medication, it's PPIs before breakfast, antacids 1 to 3 hours after meals, or mucosal barriers like sucralfate on an empty stomach. Gastric lavage assist with lavage if indicated for active bleeding. The gastric, here the dietary restriction limit food intake after the evening meal and eliminate bedtime snack to prevent nighttime acid production. Teaching the patient lifestyle changes to avoid smoking, alcohol, and NSAIDs. Medication compliance teach the patient to complete the full course of therapy, especially for H. pylori eradication. Lastly, we have for gastric cancer the RN responsibilities, the assessment, physical exam, palpate for abdominal mass, lymph node enlargement, clavicular, axillary, and check for CTES. Lab monitoring, watch for anemia, low hemoglobin, electrolytes imbalance, and elevated liver enzyme indicating metastasis. Dumping syndrome, assess for early signs like vertigo, tachycardia, sweating, and palpitation 15 to 30 minutes after meals. Psychosocial, assess anxiety, fear, and the need for end-of-life care or hospice referrals. Action, nutritional support, encourage small, frequent, high-protein, high-calorie meals. Administer the TPN or supplements if oral intake is insufficient. Emotional support, encourage the patient and family to verbalize fears, facilitate referrals to support groups. Pre-post-op care, prepare the patient physically and emotionally for surgery, the gastrectomy. Teaching for the dumping syndrome prevention, teach the patient to eat small meals, avoid high sugar foods, liquids with meals, and lie down after eating if needed. Pain management, educate on pain reporting and medication regimens. Coping, teach relaxation techniques like deep breathing and guided visualization. This slide is a very quick summary of chapter 57, patient with stomach disorders. We talked about gastritis, the inflammation, the causes, types, and treatment. We talked about gastroenteritis, the stomach flu, the nature of it, the key symptoms, primary risk, care priority. We also talked about peptic ulcer disease, the types, complication, treatment, dietary changes. For gastric cancer, the risk factors, detection, post-surgery complication, which is a dumping syndrome, management, to eat small meals, separate liquids, and avoid high sugar. We also talk about medication, the PPI, the omeprazole, pantoprazole, block acid production, and crucial for healing ulcers and gastritis. the H2 blockers like famotidine, back in the days used to be ratidine, reduce acid secretion. Antibiotics, the clarithromycin, amoxicillin, used usually to kill the H. pylori. Sucralfate coats the stomach lining to protect it against acid. So we have covered the disorders, but how do we nurse those patients? How do you answer the priority action questions on the NCLEX? That is exactly what I'm going to cover in video part 3 of this chapter. I will see you there, and to wrap up chapter 57. Thank you for watching. Bye for now.
We finally made it!
Thank you again for your time and trust. I'm Mia, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.